My name's Jared Martin. I'm the Chief Medical Officer for ART.1, but probably more importantly, I'm also a practicing radiation oncologist, both in private and public practice in Australia, and a clinical researcher with a lot of clinical trials interests. So like all of you, I'm out there in the clinic trying to solve problems every single day. And when I was thinking about how we might be able to make a really positive impact on our specialty, I really started to talk with my peers and obviously go to the various meetings, and the big buzzword now is adaptation. And the trouble obviously with adaptation is that there's the very expensive way of doing it with an online solution and bespoke machinery that might involve a huge amount of capital investment and probably really more niche indications than being a workhorse machine. And then there's the offline approach where you try to really, in a way, retrofit all of your current fleet of equipment to make it future-proof and able to adapt for the problems being encountered in the clinic every day. And so as I went around all my colleagues, it was really quite confronting to hear that for just about every single clinician, they had their own secret sauce way of approaching offline adaptation. There were some who would just lock in a replan after a particular number of weeks. There are others that would do it almost weekly. There are others who would really just wait till something was flagged by one of the radiation therapists, and really anything in between. And then even then, when asked to replan or whether a replan was needed, there was no really objective way of really deciding whether it was going to value add to actually pull the trigger and do that. It often really did seem to be a little bit heuristic about what process was being applied. And then one thing I found really confronting was the French randomized trial for head and neck cancer, which came out around about 18 months ago. And as many of you may remember, this is a trial in head and neck cancer where every week during a 7-week course of chemoradiotherapy, an adaptive plan was performed. And it was a randomized trial, so it was just compared against standard of care. And the main endpoint was xerostomia, so reduced saliva, measured both objectively and subjectively through the patient. And perhaps disconcertingly, that trial actually showed no difference at all as far as rates of xerostomia with the adaptation. And I guess my take-home message from that was, if you're just adapting blindly, you're probably not actually going to do a lot of work for not necessarily much additional value to be gained by your patients. So you really need a smart approach, and this is where ART.1 really came along, and that a group of our clinicians, we really had a two-way conversation with all of the team at C-Treat to really help evolve a package that was really slick, trustworthy, high-tech, future-proof, works across all platforms, and really didn't involve any extra peripherals. It was going to be completely software-based, not require any GPUs or anything fancy. It was all going to be something that could really just be plug and play and really add to the workflow. And also in a manner that wasn't going to be intrusive on clinician time. We really wanted something that you could really rattle through quite rapidly to be able to do decision making, and even more importantly, leave a paper trail on exactly where that decision might have come from, because billers are going to want to have scrutiny that adaptation is being done appropriately rather than maybe excessively, and so ART.1 is really an ideal tool to be able to do that. So what I really want to do now is share a software demonstration, and I'm just going to walk you through a couple of cases which I think are really illuminating. So the first one is a case of prostate cancer radiotherapy. And you can see on the scorecard of the right there of all the different structures. Some of them are in red, showing there's a major violation, and some of them are in green, showing that they're fine. And you can rattle through a trend line. And this is looking at the bladder, showing it's quite erratic. Sometimes it's red, very high dose. Sometimes it's green, so safe. And then there's the minor violations in the yellow. And when you see an erratic pattern on the trend line, this suggests that there's probably some random variation going on. And you can actually drill in here. This is the sagittal sections looking at the planning scan, but then you can toggle between that and the cone beam CT. And just looking at the bladder, you can appreciate that the bladder filling is quite dramatically different between those two scans. So that actually shows us that these changes aren't anything to do with complicated factors, this is just a bladder filling issue, which can be solved just with patient education and maybe just an ultrasound of the bladder prior to treatment, rather than needing to do an adaptation. Switching gears into a head and neck case, this is somebody who you can see there's a lot of orange lights, but also a red light on the spinal cord, which is obviously a concern. And so you can jump into the dose volume histogram here to get some idea about how the dosimetry here for the parotid is actually getting much worse than what was planned, and similarly for the spinal cord as well. So this is starting to feel a little bit more like a real systematic change. Once again, you can look at the trend line, and if you look at the spinal cord here, you can see it's drifted from the green zone for the Dmax through the minor violations, and is now staying again into the red zone. So a real concern. This is a proper established trend. And then looking at the parotid, similar trend as well, as it's drifting up and towards the red zone. So obviously a higher risk of xerostomia from treatment. So it's obviously handy to kind of drill a little bit deeper to understand why this might be. So this is where we're looking now in the coronal section. And this is looking at the cone beam CT first from the most recent treatment. And then the contours from the planning CT at the beginning are sort of on the shadow on the outside. And you can get an appreciation already from this that there's a contour variation that's occurred over the course of the first few weeks of the treatment. And you can toggle between the scans to really just appreciate that this is clearly just a loss of weight that has happened for this patient, leading to the contour variation and the dosimetry changes, and probably movement within the mask as well. So really, from all of these aspects, this is clearly looking like somebody's going to need to have a pause in treatment and an adapted plan performed or a replan performed. You can go as deep as you like. This is looking at the 50 gray isodose lines on the cone beam CT, and really showing this is now starting to touch the spinal cord, and obviously starting to increase the risk of this kind of toxicity myelopathy moving forward. So we can go back to the scorecards. We can look at the full range of patients on the work list who are all kind of got red lights, green lights, orange lights. So it's possible to jump in really quickly, and within each case, within a minute, really be able to do a deep dive and really understand exactly why there might be any variations occurring, and really craft a solution in a very objective way. So rapid, safe, trustworthy, and really streamlined, and a really exciting product that we're able to talk about today.